she is good.
Okay, so we
not
have a
long.
visual with the team. Eva is the operator, Dr. Zeleva.
Okay.
So, okay,
We were going to wait.
let's
Too late.
let's
That's not a
start
problem.
with the presentation of the case.
Yeah.
To give you a short history of the
Yeah,
first
we
case
can.
today
No, we
on the
can.
live session
Let's.
1, we are focusing on 62 years old male patient who did present in our clinic with chronic coronary syndrome with typical risk factors for coronary artery disease, arterial hypertension, dyslipidemia, and diabetes on pills. The patient did come with Doppler data for significant stenosis of right internal coronary artery, which we did confirm from the angio. It's high-grade stenosis at the ostium aprica. The patient is at sinus rhythm with normal repolarization and nothing special on echocardiography, preserved ejection fraction with normal kinetics and valve function. This is the coronary angio, which we did perform some days ago. You can observe diffusely diseased LAD with mild grade stenosis in mid-part bifurcation with very big septal as well as big diagonal branch, and some tandem stenosis in the middle part of the vessel, circumflex without any significant disease, and the right coronary artery, which is also diffusely diseased with mild grade stenosis in the middle and distal part of the vessel.
Okay, thank you very much. Do you hear us?
Yes, we hear you very well.
Okay, fantastic. So we are here in the cath lab. There are many people around, and Eva is in the driver's seat. So she is the chief today, and she already actually accessed the artery through the right radial, 6 French, I presume.
yeah.
And we are here with an EBU 6 French guiding catheter, and maybe you can show the angios that we have obtained already while waiting for you. You see the right coronary artery, it's really very mild disease, so that we in Aalst, and I think the same here in Sofia, we would not measure that. That is really not a matter of concern. We cannot improve the patients by putting stents in this right coronary artery or doing anything else. So in the left, this is the diagnostic, and we had a better shot, I think, with the guiding catheter. Here it is.
Sorry for interruption. What about the distal lesion of the right coronary, just before the crux?
We are going to come back, and if there is any doubt, we can come back and measure it. Well, there is indeed some haziness.
Yeah.
I would say a 20-30%.
In the standard aerial projection, probably.
I think it's visible also from Keldo. Yes,
Yeah.
right here.
Here, it's
Yeah, maybe you're right. Maybe you're right. If you don't mind, we are going to focus first on the left. We can come back on the right if needed, but you are right that we should not underestimate this lesion in the right now. Yeah, the right is a big vessel, but nevertheless, as you know, the right perfuses a mass which is much less important than the left system, and therefore the gradient is very often smaller than what we see in the LAD. Now, let's come back to the guiding shots, okay? If you ask me, here this LAD is quite suggestive of a hemodynamically significant stenosis, quoted and quoted. There are two other moderate stenosis more distal to the takeoff the first diagonal branch. If we have to do something, we have to keep all these things into account, because this will be probably a long stenting encompassing the first diagonal branch. But the first thing to decide is whether or not we have to do something. I will like to remember, this guy is 62, had a CVA or a TIA a couple of days ago or weeks ago. He is not fully revalidated, so the interrogation of such a patient is always a little bit more complicated. He has chest pain, which is so and so, not very convincing. His function is normal, his stress test is normal, so we have right now not too many arguments to say that these lesions have or are really asking for some treatment. So we need, in other words, good reasons to do something. So Eva already advanced the guiding. she already advanced also the pressure wire while waiting for you, and this is what she did. She equalized the pressure tracings. Maybe you can change the scale there. She equalized the pressure tracings in the ostium of the left main, as we always do. And actually, the goal of equalizing is to have both systems, the fluid-filled systems and the microcatheter, speaking the same language. That's actually what we say when we say equalizing the pressures. Then she put the wire in the distal part of the vessel to measure the single point fractional flow reserve. You can show what you have done. Do you have, or maybe you put your foot on the scopy, or
Yeah.
take.
No, we are distally.
Yeah, okay, you see the wire there, and you all know probably that the sensor is located at the junction between radiopaque and non-radiopaque part of the wire. So this is where the pressure is measured, and this is where we are to start with. Now, what about the pressure gradient at rest? And
Okay,
if it is
so-
possible, I would like to have this Coroventis screen on the big screen in the room. Is that possible to do?
Прехвърлете Coroventис към екрана
Към
на
екрана.
главния екран. Да. Okay, we
Okay.
have it.
Okay. Is it possible to have both side by side? No,
Rainer.
probably not.
Pardon?
Може ли ангелото да го
Angel-
сложите на малкия екран, а пък колегите, те са много красиви, ама може и... идеално, окей.
Okay, anyhow, it doesn't matter too much. The measurements that we are going to do is are very,
Bernard,
very-
we have on the big screen Coroventi screen and on the small screen the
Ah,
angel.
yeah,
Молите
yeah,
се,
yeah. Okay,
Rainer,
sorry, I didn't see it
кажи
for
му
me.
по-бързо.
Okay, very good.
So yes,
I'm
it's
looking.
okay.
So,
Super.
so what we have on the screen there is the resting condition. As far as we can say that the patient is really resting here on the table, what we can see is that could you decrease and adjust a little bit the scale? But what we can see is that the patient is hypertensive. This was
It's
not the
because
case.
he's,
He has to
he
pee?
has- yeah.
Okay, well, that's very interesting. It's daily clinical practice. The patient is nervous, simply he has to urinate.
Yeah.
And this is what we see all the time. When you see a pressure of systolic 190, while in the beginning it was 125, that's the first question you have to
can-
ask yourself, whether the bladder is not full. Okay, so
Yeah.
you see that
Nitro.
the effect of the bottle is very obvious. Good. That's physiology.
We're going to put
Live.
some nitro now.
Yes, you can give nitro. That's already also a step that we never should forget. We are manipulating wires in the coronary artery, so I think it's good clinical practice to give nitrates. We have discussed that earlier on. The nitrates are also there to vasodilate the epicardial segment as much as possible and to eliminate the possible vasoconstriction. Look how the pressure is going down. You have the first effect, it was the bottle, and that's the effect of the nitrates. Fantastic. Good. We have learned already a lot. So, what is the next step, Eva? So we are in the cath lab, we have resting pressures. What I would do now, since we are at rest, we are going to measure the RFR. So Valérie leads us through the Coroventis. It's extremely simple. You simply have to select RFR. You have it on the screen. I hope you still see it on the screen in there. You have to push there on the bottom, up. You have to wait for 3 seconds. It's extremely fast. And you have a value of 0.91, which is a value considered as above the threshold associated with myocardial ischemia, which is around 0.89. So this is good news, I would say. But nevertheless, we strongly believe that this is not sufficient for all the reasons we discussed already this morning. So this is the resting indices, what we also call NHPR, non-hyperemic pressure ratios. And you remember probably that this is the ratio of the distal pressure divided by the proximal pressure somewhere in the cardiac cycle where the distance between the both is the biggest. That is how you have to represent the RFR. It's very, very similar to IFR. It's very similar to DPR. All these NHPRs are actually almost identical. Their definition is a little bit different for simple, I would say, commercial and legal reasons. But actually, the net result is that all these ratios are the same. Biologically, they are the same. Good? And the cutoff value is 0.89. Let's move now to hyperemia.
Yeah.
We have seen with Frédéric this morning that there are many ways of inducing hyperemia. And it's interesting because the microcirculation is extremely sensitive to anything. So there is a reaction which induces hyperemia even with saline. If you induce a big bolus of saline, you will also have a hyperemic response. But what we know to maximize hyperemia is to inject papaverine. In the left coronary system, the doses of papaverine is between 12 and 15 milligram. You
Yeah.
agree
Yeah.
with that?
Yeah.
With adenosine, you have a very large window. Nothing can happen. But with papaverine, we have to be a little bit prudent. We should not give 30 milligram of papaverine in the left system and the same in the right. No, we have to stick to the data, namely 12 to 15, 16 in the left and 8 to 10 in the right. We know this induces full hyperemia. And this hyperemic response lasts during 20 seconds. We have a nice plateau of 20 seconds, 20, 25, 30 seconds. And this allows us to perform a pullback, a manual pullback. So I let you demonstrate. I hope you can film this, simply because, of course, the setup of the lab is not exactly the same. Wait a minute. Wait a minute. We are going to record everything to do it as well as possible. The first thing to record is the resting gradient. So please record. Good. At that moment, we record the resting values, and this is a kind of, how would I say, holy moment or mystic, a timeout, yeah, timeout moment where nothing should move, and then suddenly, very quickly, you open the PA pressure, you inject what you need to have in the coronary artery, you flush that as soon as possible, as quickly as possible, and you reestablish the PA, and you see that you follow this on the screen. What you can also do, Eva, is to disengage a little bit. You push the wire a little bit further, and you disengage. And now you don't...
No. It's it's jumped.
Okay. Good.
That's because
not a problem. We are live, and actually it's also the first time
the good point is that you have a good, almost perfect, almost.
An almost perfect what?
Equalization.
Yeah.
It was not.
Okay, not a problem. We are going to repeat everything.
Okay.
I just have one question, mainly to Kuda team. Did you give
don't worry.
lidocaine
Put it there.
before giving papaverine? Eva?
Pardon? I couldn't hear.
Did
The
you
question,
give
we are going to
lidocaine
take- we are going to take the
before
questions.
papaverine, the strategy which Valeria established more
Yes,
than 15 years
we
ago?
We did.
Okay, you
We are
go
not
back
sure
to the
that it is
coronary.
working, but finally,
But we have to remove
just to
the
save on the
diamond
safe
reduction.
side, and I have the impression, probably we should make
Why do you remove it?
a
Because
study
I need the wire
that
to
the number of
engage the
ventricular tachycardias
coronary
are
artery.
quite low.
And
Probably we should
need
do
this
a
wire.
randomized
Sorry,
study to see whether it has some effect.
Adrian, can I ask you,
Just
what's your
because I see
protocol?
the colleagues
What's your
to the
protocol?
right of me
Marla?
that
свій перший
this is
рецепт
a
дай.
strategy which we established with Dr. Gelev 15 years ago when we started to give 50 or 100 milligrams of lidocaine before 1 minute before giving papaverine, and we practically abolish all the VTs incidents.
Yeah.
And at the moment we have maybe more than 1,000 patients done during the years in that way. Unfortunately, in typical Bulgarian way, we don't publish that.
Yeah, but Nikki, this is very interesting what you are saying, because this is very practical. We are here to learn. I never heard about this. I never heard about your experience, to be honest. And this is definitely something we should share with the colleagues. We are about to publish a report, let's say, establishing the rate of VT-VF that we have with papaverine, and it is around 1%. That's a value we have to keep in mind, 1%. Of course, 1% is not that much, but it's annoying when it happens. Huh? It's annoying, and if we can decrease from 1% to 0%, it's a major achievement. So I would strongly encourage you to try to publish this, even if a short report, because this is so simple to do that it is worth to be done.
Maybe if you join to us, it will be easier.
Yeah. Okay, we'll discuss that offline. But
Absolutely.
this is a possibility.
Dr. De Bruin, can I ask you, how do you perform the RFR? As I know, when
you're
you
right.
do saline, you can, at the beginning, lower values. You wait to stabilize that values, and after that, you measure the RFR, let's say, 3 times, or you rely on one
No.
measurement?
No, I do not believe it is important to measure that several times. If you are really at rest, you take your time. You are not in a rush, and the patient is in resting condition as much as possible. I think you should not repeat that.
But one question more. We have noticed that when you flush with, let's say, relatively cold saline, there is a drop in the index that we measure probably for a couple of seconds. How this is explained?
You allude to what? To the fact that the
Yes, the effect of the cold saline that
yeah.
with which
Okay.
we flush the...
Yeah. Okay. Now again, if you measure the non-hyperemic pressure ratios, well, you have to be non-hyperemic as much as possible. And therefore, I think it is important to be careful and to wait enough. What should never be done when you do physiology is to rush, and to...
Rainer,
I think we are experiencing problems with recannulating the vessel. This is
then
really a frustrating situation for Eva. But there is no rush. We have plenty of time. The goal of this presentation is to simply show how we do, and this is something that we recognize at our place. It happens all the time, that we spend more time than we wish to recannulate the left main, and we will not put Eva under stress. Take it easy. Change guiding if you want. Are you going to take a new one or a
we'll
Judkins?
exchange with Judkins. Will.
Okay, we'll take a Judkins. Take it easy.
Adrian, can I ask you, do you rely only on non-hyperemic indexes in your practice, or you usually do, let's say, RFR, after that vasodilation, hyperemia, and do FR always, as a protocol, let's say?
I always do, but we never rely on only non-hyperemic, so we always induce hyperemia.
And do you experience sometimes, let's say, surprises? You have negative RFR, but you have very positive FR.
Nikki, maybe we can make some quiz about through the panelists. If the FFR is positive, but RFR, DPR, or some non-hyperemic index is negative, it's normal, would you proceed with PCI? Yes or no? Positive FFR, let's say 73, 0.73, and RFR is 0.91.
Definitely,
Better
yes.
now.
I would definitely go for PCI. That's the point, especially in focal lesion. We know that we have this discrepancy, and we see this not all the time, but quite often. I would definitely go for PCI.
Дай водичка наново.
Can I just
Definitely will go for
Dr.
PCI.
Guggenhoff?
can I add to that point that you've just made there? I hope you can hear me.
Yes, we can hear you.
When we're talking about these
Noah.
non-hyperemic pressure ratios, well, all of the studies that
Rainer.
are trying to understand how good these are
Noah.
at predicting something are using FFR as the gold standard parameter. So you should try and understand that this is a way to avoid inducing hyperemia, but we still accept that FFR is the gold standard. So every study that compares IFR or
Zet Noah,
RFR
Noah.
is comparing their predictive power against FFR as the gold standard. So FFR is what you should be really
More
counting
than
on,
more.
and non-hyperemic pressure
Yeah.
ratios are a surrogate that you can use if you don't want to induce hyperemia. In this particular scenario where we have a pressure wire already down this vessel, it's kind of insane not to induce hyperemia and get the gold standard measurement.
Yeah.
Thank you for that comment.
Yeah,
As you
I-
can see, we successfully engaged the left system. Maybe it's a Judkins left.
Yeah, it's a good old
Bigger one,
Judkins.
Yeah.
The bigger one, yeah. Because previous time,
Eva, as far as we saw here, the FFR was 0.86 and RFR was 0.90,
press
91, yes?
Test.
In the, or you will repeat the measurement?
You know what? We have changed the guiding. We will repeat, I would say, almost everything.
Okay.
And again, we are here to learn from each other. We're going to repeat it at our ease, no rush, equalization at this level. And I have to say here, all the troubles were induced by my remark to push on the wire, so it's entirely my fault. So now we are going to re-equalize. And by the way, you see that we need to re-equalize. It's never a luxury to re-equalize because theoretically the pressures should have been the same, but they were not the same. So can we?
we flushed the contrast and now we're going
Okay.
to equalize.
Eva is completely right. Equalization, I forgot it, but has to be done with the guiding flushed with saline. It's better. It's not 100% mandatory,
now
but it's better. It's
I
cleaner.
think that we're ready
So
for-
we are one, we are all very happy. Please proceed. So we record that. And
Yeah.
what we do in our place is we also film the position of the where we equalized. Not, it's always the same, but at least we.
I personally
Can
prefer
I
to-
ask a question?
Yes, Ravi?
So is there a natural decrement in pressure even if the vessel is normal? The further your transducer is from the guide catheter, i.e. does the distal pressure naturally go down the further you are down a vessel?
So Bernard, your comment about this, the natural decrease in distal LAD of the pressure and the difference, different values going down to the left, to the length of the vessel, or from the other panelists?
Yeah, does that really happen? Does the distal pressure naturally go down? It should because there are very many branches, so.
So there is some data in angiographically normal coronary arteries, and
Right.
what you mostly see is that in the LAD, the very distal you go, the lower the pressure goes. This is mostly due to, one, the mass that it subtends, and two, because there is always a bit of tortuosity in the vessel. A third factor to take into account is the little hydrostatic pressure, because
Right.
you equalize at one point and actually the LAD moves up from where you equalize. Since you move your pressure transducer, there is a very little effect of hydrostatic pressure, which is probably not clinically relevant. But nevertheless, this accounts for sometimes when you measure a completely normal LAD, it's 0.96 or 97 in the very distal point.
So then my question will be, is it better to keep the wire closer than further away, only in the LAD? Because if we have borderline values, does that make a difference, you know? So it may be okay to keep the wire not that far down a vessel, but just beyond the point of interest, whether it be diffuse disease or localized disease, don't get the wire too far down.
No, I think you have a valid point. Don't put the wire all the way inside the very distal side branch, but more or less like 2/3 of the vessel. But
Right,
keep
right.
it long.
Yeah, yeah.
Keep it distal enough from the lesion,
Correct,
not just
correct.
after the lesion. You need to interrogate the vessel and not just the lesion.
Yeah, that's more pertaining to the LAD.
Okay, what is, so summarizing the discussions are...
Bernard, your microphone is not working at the moment. Probably we should ask, okay, that's,
Yeah,
okay, дайте на мобилния микрофон.
yeah. it
Okay,
is
I will answer this question and then we will
Okay.
allow Eva to go with the hyperemia.
Okay.
So you put the wire approximately at the place where Eva put the wire right now, which means there. That's, in my opinion, a very fair place to put the wire. The only thing you should avoid is to push it really in the very, very, very distal part, because then you induce accordion effect of the vessels, and that's really something we should avoid. That is one. Second, when you measure the fractional flow reserve at this stage, you take into account the entire resistance of the epicardial vessel. Number 3, when you will pull back under maximal hyperemia, the PPG will tell us how this abnormal resistance in the epicardial vessel is distributed along the length of the epicardial vessel you are pulling back. So that's a kind of summary. And the points alluded to by Adriaan were very well taken. Of course, the pressure will go down a little bit when the vessel is irregular. And then there is this artifact which is related to hydrostatic pressure. But this is something we are not going to discuss here now, because this is going to delay the procedure. So I see that Eva is ready with papaverine. And again, I would like to emphasize the fact that the quality of the pressure tracings should be optimal. So, Valérie, could you record? So you push on rec. And again, we are going to wait to be patient. Wait a minute,
Okay.
Eva.
Yeah.
In our cath lab, I sometimes ask the nurses to count loudly all together to force ourselves to wait. Now, I think we waited now long enough. We have at least 10, 12 seconds.
Okay.
But this gives nice tracings. Now you disconnect the PA, you push the papaverine. You do that relatively briskly. You flush that with saline, in this case, and you reconnect the PA. So the total disconnection time has been of approximately 8 to 9 beats. And you see that now you have a nice steady state. You can pull back maybe a little bit the guiding, not to
Yeah,
repeat the
right,
same
yeah,
mistake.
but
I know,
take
I know,
off.
I know it's difficult. But look at the difference. Look at the difference. We are getting very close to a positive value, 0.82. I'm not saying that to really force the value to be positive, but you have seen that pulling back the guiding decreased a little bit the value of fractional flow reserve. Why is this? Well, simply because the guiding induces a second stenosis, which is not natural. You also see that we have a fantastic steady state. That's a fantastic plateau. The PD doesn't change at all during 20, 30 seconds. It's good to keep this in mind, because in 2 or 3 minutes, we will perform the pullback, the pullback. And we have to make sure that the plateau is long enough to do this pullback. Now, to be consistent and to do each time the same, I will stop the measurement after 2 minutes. Strictly 2 minutes. People working with me in ALS know that I'm a little bit obsessed with these 2 minutes, but you will see why here. Here is why. Look, this is a perfect pressure tracing. You may like it or not. You may say, well, that's not exactly what I wanted to see, but this is the true physiology. You have a nice resting phase. You have the disconnection of the PA, which is, of course, always a little bit troublesome, but here it was relatively short. Then you have the induction of hyperemia, and here you have a nice steady state. And you see that the steady state lasts during approximately, what? From 50 to at least 80 and a bit seconds, so plenty of time to do the pullback. But also important to see, don't do your pullback already here, otherwise you will mess up the PPG value. You have to really do the pullback when you are fully hyperemic. And since this value is 0.82, it's a non-ischemic value, quoted unquoted. Theoretically, we can stop here. We can stop. In many cath labs, people will stop here. Well, to be honest. In many cath labs, they will bang a stent anyhow, but in people who are following physiology, they will stop here. Now, what I would propose, since we have time, and I look to Valérie, why not to do that again? The simple tracing, just to show how good you are in making it reproducible. Okay, good. So, advance the guiding again in the coronary artery, just yeah, like this. We are going to. You are ready? You have papaverine left.
Aussteding papaverine.
Okay. So, you see that the PDPA ratio came back to the
Right.
original value,
Papaverine aussteding.
and you have saline. That's also reassuring, because if the value comes back to the exact same value, it means that most likely the patient is really at rest in conditions which are for him the best possible resting conditions for his physiology. So we are going to wait for the papaverine. Okay.
Bernard,
Yes?
could you even repeat this measurement with adenosine just to have this direct comparison? That will be
You have it?
great.
No. Well, we have no adenosine here at hand.
Oh, sorry.
But you're right. We can play around a little bit since we have time. And we are here to learn. We are here to do these kind of demonstration. My best guess is that adenosine would show the same value, but a very short plateau. Actually, almost no plateau. And you know, physiology can only be done. You are ready to go?
Just
Okay.
for the audience clearance, now we will test the reproducibility of the
Yes.
method, of the measurement. Do you plan to test also to make a measurement by infusion with adenosine, just to see?
Okay.
It will be good.
So
just,
we started already.
Okay.
We started already.
Okay,
Since
so-
wait a minute. Since 9 seconds.
Okay, nice.
She is too much in a hurry. Okay, now you can do. So we have recorded 17 seconds. That's more than sufficient. Okay, papaverine, saline, as quick as possible. I say as quick as possible, not to rush things, but simply because I don't like this disconnection of the PA.
Double.
Okay.
Double. What's your experience with intravenous adenosine?
Okay. Switch it down.
You can get a steady state, you can get pullback. So we use it all the
My personal experience in Bulgaria is very limited with the intravenous adenosine. We used what we are doing in our cath lab. We go with step up intracoronary with the 60, 120, 180, and 240 micrograms up to the almost complete AV block, as much as the patient can endure. And if there is a diffuse disease, I'm waiting 3-4 minutes, and we give papaverine, and then we check again, repeat measurement, and make a pullback, just to measure. This is what we do in our daily practice, practically every day. This is our strategy. Just because of we don't have any problem with obtaining adenosine, at least in our center, this is not a problem. But I have some logistic problems with organization in the cath lab and with the infusions and everything else, especially for adenosine. And this is the strategy we adopted for our patients.
We routinely use intravenous adenosine with the central line, and you could.
Okay, guys, we are playing around here a little bit in the cath lab, and I hope you see the screen. Yes, you see the Coroventis screen, and Eva did exactly the same as during the first tracing, and look at the value. You see the 0.79. What happened there? And I put the question to you in the panel and in the audience.
Can I because there is sometimes from the last nitroglycerin, and sometimes maybe if you repeat nitro and then papaverine probably it could be that you will repeat your initial value, because now the action of nitroglycerin is around 2 minutes, and I perfectly sure that we are much more than these 2 minutes, and maybe it could be that the action of the wire per se could induce some small spasm, and this could
So what
explain
is
this.
important here, if you look at this tracing, is that the value that you see, the FFR 0.79, it's taken on this yellow line, this vertical yellow line. You can move the line through the complete tracing, but this is actually taken in the part where the PEA is open. So when she injected the papaverine, this is a wrong value. So you should move the FFR line more to the right side.
So that's a very good point. That's the explanation, of course. The machine is told to take the lowest value. Yeah, keep it there. To take the lowest value. And of course, the lowest value here is an artifact. It has nothing to do with fractional flow reserve. But nobody have seen that. And 90% of the interventionists, they will look only at the number which is written there on the upper right corner. Now, when you move it at the right place, is 0.82. But is that the first tracing or the second one? That's the second one.
The second one.
If I recall correctly, last time, 0.82.
Yeah.
So let's, Valérie, show me it was the first one or the second one. That's the first one. Show the second one, please. 0.82. So I think this is a live demonstration of repeatability. And there is no index. You will be a little bit surprised what I'm going to say, but there is no index in medicine, probably, which is as reproducible as this. And this has to do, all to do with the hyperemic values and the abolition of all these autoregulation that we have discussed this morning. Now, to continue on our line of playing around with the tracings, and except if there is a question, I would like to go live again, and I would like, do you still have papaverine somewhere? Give another. We are going to go live again, and I will ask Eva to give us hyperemia, but we are not going to record FFR, we are going to record RFR, the so-called resting gradient. Why do I like this demonstration? Because you will see that probably these values will change. Now, remember, if you are very in the physiology, the basic principle of developing IFR was that during diastole, the resistances were minimal naturally. And we are going to demonstrate that this is complete nonsense, and that therefore the basic theoretical fundaments of resting indices is crap. Let's do that. Okay, good. Are you ready with your papaverine? No.
Yeah.
We are not going. We are going
Just
to go
a
with
moment.
this, but we are going to wait for the measurements to be hyperemic. So remember, the value was 0.91, and it is still 0.91. 93. You see, by the way, it's a little bit variable, but okay, that's not a big variation. Whenever you want, we have plenty of time. We have plenty of time. No.
So the plan now is to do what?
Well, the plan
CFR?
is the plan is
RFR, okay.
to repeat RFR, but no longer at rest, but during hyperemia, simply to show that RFR and IFR and DPR actually change during hyperemia. Please induce hyperemia. If I'm getting boring, you have to tell me.
Okay.
Okay, go. And you flush it. We are not going to record. We are going to wait the, let's say, 15 seconds are needed to induce hyperemia.
I'm just wondering, by doing hyperemia, are we measuring RFR or diastolic FFR?
That's a very good point. We will discuss that. Look at this. Look at this. I'm going to record RFR now.
No, disengaged a little.
And you have a value which is 0.79. Now, theoretically, if the theory of IFR, as described by Justin Davis, was true, we should not see a very significant difference between non-hyperemic and hyperemia. And look at the difference between 0.91 to 0.77. It simply means that during diastole, the resistances of the microcirculations are not naturally constant and minimal. I will close this parenthesis because I realize very well that I'm confusing everyone, but I think it is important to realize all these nitty-gritties of coronary physiology. And
But now we have even more confusion because this value, which we see on the screen of Coroventis, is below 0.80, which is significant. And
why
what to do? Because now we have a third value. We had a one value at rest. Then we had a FFR, which was non-significant. Then we had a catch with the FFR of 0.79, which was definitely wrong because of the probably stopcocks or something like that. And now we had RFR of 0.76 minimum, and the point is what to do.
Well, what to do is very simple. Here we have a non-ischemic lesion. We have FFR, we have RFR. Forget about the demonstration of hyperemic RFR because this is nonsense. The goal of doing this was simply to show that during diastole, because RFR is measured during diastole the resistances are not minimal as postulated by the inventors of all these non-hyperemic resistances ratio. So, for what?
May I have one
No, we
suggestion?
cannot rely on this. This was just for the sake of demonstration that I asked you to induce hyperemia again. So what I would suggest now to close this case in terms of physiology is to demonstrate the pullback. Do we have 2 more minutes? Yes, okay.
Do you plan about to do measurements in the right coronary?
Well, that's a good point.
Distal right, because there is another lesion there,
It will be
and
negative,
the vessel is
Okay,
quite big.
Okay. That's very well. We'll do that if you allow me. Eva told me already it will be negative. We are going to concentrate on one single detail in the right. Please take papaverine again, and we are going to do PPG. Well, not the real PPG, because this console is not yet equipped with PPG, but we are going to demonstrate how easy the pullback is. Eva never did that during her life, and she is very experienced, but she will demonstrate us how easy it is. We will do that together.
And we're coming to a very important point, to do a pullback in order to check if there is any drift, because we have values that are very close to the positive FFR, so we have to confirm that these values are real and we can rely on them.
That's a very, very good point. Drift is the most annoying problem in everything, in every measurement. It happens in all the measurement devices that you can dream of. Even the atomic clock is drifting, just a couple of tenths of seconds every 2 or 3 centuries, but it's a drift. So what we are going to do is the following. Look, we are going to induce hyperemia. You can do that already. We know what is the value of FFR we have to expect. It's 0.82, 83. At that moment, we are going to record. You are going to put your foot on the scopy, look at the screen. You say, top, I record. I pull back. I will record. You manage to do that in 20, 25 seconds regularly, and we are done. Okay? So,
Bernard, before you do that, may I have a suggestion there?
Eva is fantastic. Okay, good.
Bernard, can you hear me? This is Joe speaking. Hello.
Yes, I think we hear you.
Yeah, thank you.
your flash
May I have a question and
Yeah.
a suggestion there?
Okay.
Since this patient has a non-ischemic FFR and you conclude that the epicardial compartment is
We're
not
ready.
consistent with his symptoms,
Wait a minute, huh? Wait
can
a
we
minute.
assess the microcirculation? Since you
Just to
use
disengage
papaverin,
the
and
guy
measuring
before,
IMR or CFR for that matter is easy. And the question
Yes.
is, how many times can we actually repeat papaverin reinjections safely?
Okay, could you keep this question for the end? Because we are close to the... Wait a minute. Okay, you are ready with your fingers on the... You
Yeah.
tell me when you record, when you start. Okay?
Okay.
Start, pull back.
Starting pullback.
Stop. Okay, rec. Okay. You record, you pull back. You pull back.
Yeah.
A little bit faster. Okay.
It should be done in 20 seconds, right?
20 seconds. She is very stressed because of these 20 seconds. But look how progressively... Okay, go on, go on, go on. Never stop.
Someone has to count it.
Yeah, that's true. We have to count. But it makes things even more
Maybe
stressful.
may-
Okay, pull back a little bit faster. A little bit faster. And what is important is also to know, this will be a relief for Eva, is that if it is 20 or 30 seconds, it doesn't matter too much. And you tell me when you arrive in the guiding, okay?
Okay, I'm close to the guiding.
No, in
In
the
the
guiding.
left main.
Stop.
Up.
Okay. We have
It's out,
stopped.
yeah.
Okay.
Perfect.
Well,
This,
look.
artery engagement
Of
is-
course, here in this case, for us in ALS, it looks a little bit weird because now we would have the PPG here in the corner of the screen, here, and it would give us a value which will most likely be very, very, very low. So in spite of this small jump here, which is probably related to the lesion, this lesion that we see is actually responsible of only a hyperemic pressure gradient of 5 millimeters of mercury. And the PPG, but that's guesswork, of course, because it's not calculated by a computer, will be, Tabo, you agree, 0.42 or something like that. Very, very low. And you realize that during hyperemia, there is resistance. There is an abnormal gradient which disappears progressively here, and this corresponds to the small bumps that we have seen
Yeah,
on
yeah,
the
this,
angiogram. This is
diffusely
one. This
disease
is a
segment.
second one, but
Yeah.
we are not going to cover this from here to here with a 38 long stent, just to win 5 millimeters of mercury. That is applied coronary physiology. Thank you very much. Congratulations for your first fake PPG. Good. Well, that's for you. The applause is for you. Yes. What?
If the FFR we measure was below
0.
at 0.8, what we are going to do?
Yeah. The question of Valérie was, if the FFR would have been 0.72, for example, well, then we have to be consistent. If we say, okay, we go, then you forget about physiology and you focus on what you have to do for the patient, and most likely you will have to cover the whole segment. It's important to say you forget about physiology, because then you have to really focus your mind on what is important for the patient. We promised to someone, to Dobrin, I think, to measure the right. Do you agree to measure the right? Okay. She agrees with everything.
She's my friend, so she will do it.
Okay, no, she is very, very
will do it for
easygoing.
me.
I fully agree.
Moreover, that we have 52 minutes for life.
Yeah, and by the way, Dobrin, we forgot
Yes,
to
the
check the equalization, but we see that it is perfect.
Yes.
We see that it's perfect, but it's a very good point. I forgot, and you were right to mention it.
Maybe one comment, Bernard, I don't know what you think, but during this maneuver, sometimes, if you don't pay attention, your guiding can dive into the left main or in the right, and then your measurement get completely wrong. So
Yeah.
maybe one comment would be to, while you are pulling back with your right hand, it's important to really hold the guiding with the left arm.
Yeah.
To fix.
Yeah. Well, maybe you can explain that further in the room, because we are going to quickly swap for a
Maybe
guiding
it's
for the ride?
important just to repeat it once again
Yeah,
because of
because
the
as you all know, when you are doing PCI, when you remove material, when you remove a balloon or a guide wire or anything, sometimes it's not the material that is coming back, it's your guiding that is going in, right? So we all know this when we are doing PCI. So that can be actually the same. While you are pulling back your wire, sometimes your guiding catheter dives in. And if you have some disease, especially if you have some disease at the ostial part or the proximal part of the artery, then you can ventricularize your operation, then you get a completely wrong measurement. So we have to, as it was very well demonstrated, be sure that the guiding is a little bit extubated, and we maintain this position while we are pulling out to make sure to have a very nice tracing.
And always keep your eyes on the pressure tracings.
Yes, that's true. You know what, Frédéric, we will come back on this particular point, which is probably the biggest pitfall in measuring pressures in the coronary arteries, namely the positioning of the guiding catheter in the ostium. We will come back to that during the limitation talk. But you are right, and it's right to stress and to repeat it several times.
Bernard, just to go back to my question about the RFR and diastolic FFR, by doing RFR during maximum hyperemia, because this is very close to, if we take the complete, the whole diastolic period, and the whole diastolic period, and during that time measuring FFR, it is, let's say, the principle of diastolic FFR, and what we measured during this measurement was practically diastolic FFR, not an RFR. Yes.
I'll take this one. So I think it's really important to understand exactly what RFR is. So it stands for the rest in full cycle ratio. What it's doing is trying to find the moment in the whole cardiac cycle where the ratio between PD and PA is at its lowest. So when you actually look at an RFR tracings, you'll see a little cross.
Увеличете микрофона, силата на микрофона.
Can you not hear?
No, it's work, just our guys decrease the volume of the microphone.
So it's looking for the moment in the cardiac cycle when the ratio between distal coronary pressure and aortic pressure is at its lowest. And you'll see when you look at an RFR tracing that it's a little cross. Okay? FFR is the mean hyperemic ratio for the distal coronary pressure and the aortic pressure. It's not a single point in the cardiac cycle. It's the full cycle, and it's the mean of the PD divided by the PA. That's what's been validated. That's what's been validated clinically for studies like FAME. What Bernard just demonstrated there was a completely artificial scenario where a single point measurement, an RFR, was taken during hyperemia. It's not at all validated. If you were to take the mean of the RFR, I suspect it would have been above 0.8. Just to answer the question.
I mean the physiological point of measurement, not what is RFR as general measurement.
I think we've confused you about doing that. It's not a validated thing. It was a demonstration that RFR varies between rest and between hyperemia. That was really what it is. That single point value you should just ignore. That was just a demonstration.
So this right catheter is a little bit okay. Now it's better.
I cannot agree more with Tabo. I should not have done this demonstration of hyperemic RFR. There is nothing like diastolic FFR. You can measure that, of course, but this has never been demonstrated. So we have to stick to what we know, namely RFR and FFR. So in the meantime, Eva went to the right. It's Judkins right, 6 French. The equalization is already done. She is manipulating the wire a little bit delicately, because on one shot we have seen that there was maybe something in this distal right. So what I would suggest, once the wire is distal, Eva, maybe give us good shots, good angios to have a better look at the vessel, if you don't mind, because there was one still frame where we both have a depth here in the lab. Okay, this is what we have seen already. Let's have another look.
That's because I heard that Nikki said that the caudal view shows
Yeah.
us.
Okay. Oh,
this
that's
gradient.
extremely interesting. Oh, that is interesting. Good. Well,
But
let's
still,
play around with this new
think it-
fact. We completely missed this gradient. This narrowing. But
the
nevertheless,
bottom
what I see on the screen of the Coroventis is that the pressure remains fine. So it's probably a very eccentric lesion,
But still,
which-
it will be negative.
yeah, which might be considered 90% by the aficionados of stenting, but I can tell you this is not 90%. This is simply in one projection relatively tight and not in the other one. So we are dealing with the resting gradient. Could you give a quick shot? Yeah, okay, that's
David,
extremely interesting.
Вода.
I would put the wire a little bit more distal and then give papaverine, and we are going to record that as well as we did for the left.
That
And before
contraction.
doing this, Eva told us, oh, this will be negative. Well, what is, of course, now you are biased already because, don't do it now.
No, it's just water.
Just water.
Saline.
What is your best guess of the FFR in the distal right? In the panel? Frédéric.
Дай водичка само напред.
I would say negative for sure. I would say 93 or 93.
93, okay. Well, I let you collecting the other opinions. And in the meantime, while we are waiting at rest, I would
What do you
like to
think,
make
guys?
another comment. Can you simply, keep your foot on the scopy so that we all know where the pressure is located? We now just injected saline and contrast medium, which are hyperemic. And I would like you to wait for another 1 minute because I observed a phenomenon there in the distal right which is intriguing. There is actually virtually no pressure gradient, but what happens sometimes when you advance the pressure wire in a big right which is normal is that the PD, the green signal, is actually above the red signal. How is it possible? Do you think the blood is circulating in the other direction, or what is the mechanism?
Hydrostatic pressure and difference.
Yes, hydrostatic pressure. It's obvious. I think that you know that very, very, very well. But it's sometimes surprising. You say, what happens there? And you repeat, you come back, it's equal, you go distal, it's a reverse gradient. This is an artifact, okay? And there is no need to re-equalize when you are in the distal part, otherwise you induce a mistake. So, Eva, yes?
Just to ask, this phenomenon is seen when there is a bypass also.
The phenomenon is seen when there is a bypass?
Yeah, this phenomenon to PDB above. Yeah.
Actually, the presence of a bypass does not change anything to that.
Yeah, okay.
It might even be more pronounced because the bypasses are implanted at the very anterior wall of the... Okay, anyhow, we are diverging.
You will proceed.
So we are ready to induce hyperemia, and we are going to do that as carefully as for the left. So wait a minute.
Wait.
So you know me, eh?
Yes,
Okay,
6 seconds.
good.
7.
We are going to record.
Sorry, Bernard.
Time out.
About the RCA distal part, it's the eccentric plaque. We do FFR and all this hemodynamic analysis, but can we make a structural analysis of the plaque, OCT or IVUS? Because structurally, this plaque look eccentric and quite sharp. And hemodynamically, as we see, it's okay, but are we confident to leave this plaque as it is because of the, I don't know, maybe temperature and rupturing of the plaque.
Yeah, as disengaged.
Yeah, I think you're right. It's a good point. It's a very good point. And at a certain point in time, we will probably put stents in these kind of lesions, even if they are hemodynamically non-significant. And what we are observing here is, for me, extremely interesting. This is not at all what I expected. But this is a big rite, perfusing a big territory, and therefore we had the fractional flow reserve, which was as low as 0.83. So actually almost the same as in the left system.
Sorry, Gianluca, the wire is in the PL, right? Not in the IVP, not in the posterior descending, is in the PL.
Yeah, that's true. We could, well, if you want, we can repeat it in the other branch. Most
But
likely it will be the same, but it's a good point. It's a good point.
I don't think it will
That's
change something, but
okay. Wait a minute, don't touch anything.
Could you maybe inject a bit of contrast to see if it's accordion of the proximal, right?
Yeah, okay. Could you do that? We
Yeah.
have stopped the recording. But again,
Yeah,
you see
contrast.
how nice the recording is. Yeah, okay.
Дай още контраст.
Okay. Can we see that again? Yeah, okay. No, I don't think there is accordion.
No,
And
this
I
is a
don't
lesion proximally.
I
There
think
was this.
you know, this eccentric lesion, which was visible only in one projection, was already present without the wire. So it's certainly not an accordion. And I think we are done. Now, the only thing which remains is, of course, to go for imaging. But imaging, yeah, what will you do if you do OCT and you have a thin plaque fibroateroma? What will you do? What will be the consequence? Will you put a stent there in a patient who is almost asymptomatic? Or do we simply say, well, that's an incidental finding?
Probably this is the crucial point. What is is the patient has an angina or some shortness of breath or some
No.
clinical signs of ischemia? Did we have some non-invasive test of? I don't know. I know that in Valeri's clinic they do a lot of dobutamine stress echo.
We didn't do.
This patient was decided for functional assessment. That's why we did not do stress echo, but we can do it on Monday. That's not an issue.
What was the reason for the CVI? It has a CVI 3-4 days ago, Dr. Gelev.
2 weeks.
3 weeks ago. But
3
the
weeks.
CVI was, what was the reason for the CVI?
Stenosis of the carotid artery, right carotid artery.
Aha. Not atrial fibrillation,
No,
paroxysm?
no.
It was a
Okay.
diagnostic,
Yeah.
Okay. If you do not mind, I think we are going to close the case. Summarizing this case, 62 years old, patients with quite atypical symptoms, we have to say. A lot of risk factors, of course. LAD and RIDE show moderate lesions. These moderate lesions are typical indications for pressure measurements. We think that it's, for time being, it's right to stick to the rules, I would say, and to defer both lesions. We have no real good reason to put a stent in them, and we are going to close the case, period. Okay? You agree with that?
Okay.
Thank you very much,
Okay,
Eva.
thank you so much.
Let's pull back sound. There's a question. Just to.
So, some concluding remarks from the panelists. François?
Maybe they're switching to the next case in the cath lab. Am I right?
Do you have prepared the second case?
Can we have a
Patient now,
connection
and
with
to have
the
another
cath lab?
one? Okay, that's good. And I would like to come back. I do not forget you, Scholt, with your questions about microcirculation. I think that the next patient is a typical ANOCA patient, or almost typical ANOCA patient, and we will have more time to focus on your request.
So we are waiting
Okay.
for the second case, Nikki.
So it will take 10 to 15 minutes, okay?
Yes, right now we are switching the cases in the cath lab, so there is a place of discussion.
Just to point out, because I just checked about the diastolic FFR, there are 2 studies, and there is a second study, the most recent. The first one is from 2000, and the second one is from 2021, done in Japan, almost 400 patients, where they did it against the myocardial perfusion imaging, and they did exactly the diastolic measurement was through the whole diastolic phase, and it was actually what we saw what is the principle of RFR. RFR takes the whole diastolic, mean diastolic pressures at rest, and this is the principle of RFR, okay? And during hyperemia, this is diastolic, this is diastole study, just what...
Yes, but in the end, I mean, we probably need to stick to what is demonstrated from patient outcome perspective, and this comes from DFAIR and the FEM trials, and in those trials we were using conventional FFR. So that's certainly interesting. That's maybe something to explore. But for now, I would stick to the conventional FFR to take clinical decision for patient outcomes.
No, just we are talking about the type of physiology here, not for the outcomes, not for the clinical outcomes, not for the, it's absolutely decision making. Yeah. This is not for decision making. This is just theoretical discussion at the moment. Dr. Wilgenhoff, what do you think?
I don't really have an opinion. I mean, you can measure different things, that's true, but I do question the relevance of what's being measured. Yeah. We measure things for patient outcomes, so I don't really know what I can comment.
Yeah, Dobrin, I don't know what to make of it. What is the physiological background behind hyperemic measurements of IFR, DPR? What those numbers mean? I don't
Me
think
too.
we can, there's no, this was very confusing. We saw something, but what it means, I don't think we can make any comments about it.
For me personally, I always judge first from FFR.
Yes. Yeah.
This is the mainstay. Yeah. Then mainstay, just to be clear, giving a clear message. Just this is physiologically logical measurement. Yes, Zsolt.
Yeah, thank you very much. At the beginning of this session, we had discussions about the discrepancy of non-hyperemic pressure ratios and FFR. And I think that's mostly related to diffuseness or focality of the lesions. So it's mostly in focal lesions that you find this discrepancy. And the discrepancy is even more exaggerated in proximal lesions. So to come back to the question whether or not we should rely on FFR or a non-hyperemic pressure ratio, which is negative, FFR being positive, I think we should definitely stick with FFR because it really happens in focal proximal lesions, which have prognostic implications, and that may be the reasoning behind the seemingly higher mortality rate at the 5-year defined flare data. So I think, of course, it's not only related to focality, but this is probably the single most important factor behind the discrepancy between these. Thank you.
Robert?
You know, this was a very interesting session, and just to close the problems of parameters that should be used for clinical activity. For me personally, the only implementation of PPG for FFR measurements makes, let's say, this method as useful as these other non-hyperemic parameters. But just let's close this point. I would like to come back to these intermediate lesions with, let's say, borderline functional values. What about the trial? The acronym of this trial was PREVENT. I'm talking about about stenting of intermediate lesions with the signs of vulnerability. So I would say that especially for this particular relatively young patient with atherosclerosis in carotids, I would explore these coronaries in terms of plaque characteristics. There was no need to do that in the same stage. Might be this is also a good patient for CT angiography with the newest softwares to assess the plaque characteristic and so on. But we have to keep in our mind that at least in part of the lesions, non-ischemic, as it was, let's say, mentioned, based on functional assessment, we cannot predict the natural, let's say, process of atherosclerosis in these patients. So might be we need for these patients imaging. The question is immediately on the table with intravascular method or just in a next stage of diagnosis using, for example, non-invasive as CT angio.
So CT angio for plaque characteristics, that would be quite an interesting, but maybe in near future.
I think you have a very good point. I think we need to clearly in our mind separate ischemia. Ischemia, we detect ischemia with FFR, and ischemia leads to symptoms, to angina. And this, if we release ischemia, we will release symptoms, that we know. And vulnerability, what you were alluding to, which is related to plaque characteristics, and this leads to adverse events, plaque rupture, MI, death, and we are still, we want to find a way to find those vulnerable plaques and treat them up front before they would do an hard event. That might be also something that we can have with PPG, because we learned this morning from Adrian that the pullback pressure gradient, when it's focal, it's related to adverse plaque characteristics. But back to your question, should we use CT? Well, in CT, we see many vulnerable plaque, and actually the rate of event, even in this vulnerable plaque, is like 4%. It means that if you go for a stent, you will stent 96% of patients for whom nothing will happen. So that's really difficult. I think we really need to find among those vulnerable plaques which one are the worst, which one are the most at risk. Maybe there is a space for physiology there, for the gradient. But that's definitely a very interesting field and a very interesting comment. Thank you.
But, sorry, Robert, do you remember on the session about the prevent and when Jacek Legutko during your course in April last year, what Xiaoliang Chen said about prevent? I don't trust this study because of many pitfalls of the methods used in this study. Just, yes, this is why I'm a little bit hesitated to...
Still, taking into account the power of intravascular imaging, we should this patient with a higher probability of events, we should explore with additional devices. The question is whether there is a need for intravascular imaging, which is invasive, takes time, it's much more risk, or just standardized with new algorithm, taking into account not only the plaque characteristics, but other features of atherosclerosis by CT. Maybe this is of course, this is the future. It's not ready for now, but this is the future in my opinion.
Yes.
We're discussing about when we have patient with coronary atherosclerosis. Actually, we as a doctors trying to cure the patient, not to cure the vessel. But the functional test that we are doing is something that is about the momentum of the plaque. We have to keep it in mind that the vessel is a live organism, And also the atheromatosis or atherosclerotic plaque is a life organism that is living inside and developing, growing, smalling, rupturing, etc., etc. So we always have to have in mind, as doctor says, more imaging of the plaque, all structuring of the plaque, and keeping in mind that this plaque can make harm of the heart of the patient. And if a patient has already CVI, has this kind of eccentric plaques of the right and left coronary vessel, we should considering discussing about the live plaque and treated the plaques.
I'm just wondering, Dr. Ferenc, what will be your approach in this patient?
100% sure I would go for imaging. As Robert correctly mentioned, very young patient with two-vessel disease. By angio 10 years back, we will definitely, most probably stent the LAD, even without FFR, in majority of centers around the world. And in this case, I would go at least for additional OCT in the right coronary artery, just to have information regarding the plaque. I would also ask the patient in which area is he living. Is he in some countryside area? If he would have some acute coronary syndrome and he will go, I don't know, he spent 2 hours to reach next cath lab, or just he is from Sofia here, maybe 1 kilometer from your center, maybe it could make a difference. And what you can do, if you're still not sure, you can go ahead with stress MRI, or you can do PET.
Juan, because I saw that you are reacting, what would be, can you give to Dr. Chico the microphone?
I reacted because I agree that might be a relevant point that will never be reflected in the guidelines. The social conditions of the patient. I mean, if the patient is living far away, and so probably I would move my threshold, as Dr. Ferenc suggested, and probably with a borderline result, if you take the opposite decision, you are only borderline. You can only be borderline wrong. So I do not hesitate to be flexible, taking into account the particular conditions of the patients. Otherwise, I think the evidence coming from these Korean studies on imaging, on the vulnerable plaque, etc., is too weak to make decisions, whilst the evidence on physiology is overwhelming. So probably I would tend, if the patient has no special condition that could put him in trouble if he has an event, I would tend to stick to the recommendations of physiology and to define the thresholds. Because if we trust the evidence, we should stent preventively vulnerable plaques, but not stenting the plaques which are provoking angina, according to Orbita, ischemia, and all these trials, and then again stenting in acute coronary syndromes. So we have to review very critically this evidence and selecting which is more meaningful from a medical and physiopathological point of view. So, physiology.
Okay, physiology first. Dr. Hendricks, can you give the microphone to Guy?
I completely agree that you have to look at the patient and not only at the lesions. And talking about the social condition of the patient, he said, well, if he lives in the countryside, but again, if you put in a stent and he lives in the countryside and even needs to allow incidence of stent thrombosis, it may also get into problems. So this is all speculation, but again, it's really important that research focuses on the way to look at the vulnerability of plaques in order to decide which one should be stented and not.
Okay. Yes.
Maybe it would be very nice right now to go to these details regarding what we shall do with this patient, because you know the hypolipemic treatment now is very effective. We have new agents. We have fluoxetines. We have for pre-diabetical status. We have also GLTB2 and antagonists. So we have many, let's say, possibilities right now before stenting. But you know, from scientific point of view, research point of view, this kind of patient, this group of patients should be explored much more deeper to, let's say, to be effective preventively.
Okay, because we have quite a young audience, and maybe we should. I'm a little bit now. It's a little bit frustrating for them. Actually, what we have to do with this type of patient, and I would like to ask Ravi, what will be your approach in Cleveland? I mean, this patient comes to you, and how you will approach it in Cleveland Clinic?
You have to look at the patient as a whole. So we can divide patients into obviously the acute coronary syndrome patients, where by and large the treatment is very straightforward. You identify a culprit lesion and you fix it. Then on the other hand, you have a patient that is completely asymptomatic and you don't have any other measurement of ischemia, so you have a negative stress test. We all know that stents are good to treat symptoms, and in all the larger trials that you look at, stents have never treated or prevented infarction, death, acute coronary syndrome. So that's a big issue. So we can assume that we have a vulnerable plaque, and the definition of vulnerable plaque is very loose. I mean, what is the gold standard of vulnerable plaque? Unfortunately, the gold standard of vulnerable plaque is pathology. You have to dissect the vessel and say this plaque is vulnerable. You can look at CT, you can look at OCT, you can look at IVUS, and you can say, I think this is a vulnerable plaque. That is the best you can come up with any kind of imaging modality. The next question is, okay, you've seen what looks like vulnerable plaque on OCT. What is the natural history of this? We can guess that the incidence of plaque rupture and acute coronary syndrome is going to be high. But what is the exact percentage? We have no idea. And then, as Dr. Gill pointed out, what does intensive medical therapy do to the vulnerable plaque? Maybe it'll stabilize it. We don't really need a stent. So, to make a long story short, if you have a symptomatic patient, a patient who has an abnormal stress test, the answer is more or less clear. If an asymptomatic patient with a non-abnormal stress test, I think medical therapy is perfectly fine. For intermediate lesions, we would stick to physiology, and if the physiological measurements, FFR being the gold standard, is negative, that is the end of the story. Left main, of course, is a different issue. So if you image the left main and you determine the extent of the lesion, then you can make a decision on stenting or not, whether the patient is symptomatic or not, because that is one area we think revascularization will probably prevent death, improve mortality. So does that answer your question?
Yes, you answered in typical American way.
What? You didn't get a yes or no answer?
Never say yes or no. Okay. So
Dobry, can we go deeply into the technical part of the case that we presented? We have, let's say, very close to the cutoff point of FFR, 0.82, but we didn't take into account the hydrostatic pressure. What do you think if we take it into account? Maybe we'll get 0.80. And what do you think? Do we have to treat it? Do we have to take into account, Adrian, also to you? Because the effect is decidable in these borderline cases when we have close to the cutoff values of FFR, and maybe it will weight in the direction positive FFR. Any comments?
Well, it's not really a black and white scenario. You have to see it as a continuum. And there is this gray zone between 75 and 80 where you have to look at the patient. Is he symptomatic? Does he have a stress test? And so on and so on. And just looking at this data or this value in a binary phase, it's quite simplistic. You have to take into account several factors, and sometimes if you're around the cutoff, there is no real good answer because it is the gray zone, and that's the definition of a gray zone. So I would then look at the patient in a whole and not just at the value itself.
Yeah, as Dr. Chico yesterday told us, that we're near to help or near to harm the patient. But we're close to the cutoff value.
Zsolt?
Yes, thank you very much. Well, actually, the outcome data we have, because we should really focus on patients and outcomes, and we can discuss the morphological features of vulnerability, or whether or not it's close to the borderline, whether it's a precise measurement or not. But really, we should look at the data we have on the outcome. And the outcome data come from studies in which the hydrostatic effect was probably not taken into account at all. So, and I would like to allude to the beautiful paper of Emanuele Barbato from, I think, 2016, the natural history of coronary artery disease based on physiology. And if you remember, there is a continuum of non-revascularized FFR value, non-revascular vessels with FFR related to the outcome. And it's a continuous relationship, and having an FFR of 0.95 is definitely better than having an FFR of 0.83, both being negative. But we do have more events there. Not mortality, not necessarily mortality, maybe some more infarcts and definitely more revascularizations, many of which, of course, may not have been based on physiology. But anyways, the natural history is linked to physiology for sure. In this case, in which the RCA was measured to be 0.83 distally, which was even surprising to Bernard himself, I think should call our attention to whether or not this was focal. So, and I agree with the colleagues, it was a little hazy, it was really something bad to look at from the special projection. But most likely, if we had done a pullback there, maybe the gradient would have been very focal. And I think this plaque may, or this patient, or this right coronary artery may have been a good indication for a prevent type of strategy. But in the end, we'll have to prove that this is a valid concept. So to see whether or not stenting such a vulnerable-looking plaque resulting in a focal but physiologically just not a significant gradient, well, we are yet to see whether or not this makes sense for the patient. And of course, we will have dual antiplatelet medication needed in the long run for this patient who's just suffered a cerebrovascular accident. That needs to be discussed with the neurologist. So there are a number of other factors that should be taken into account before we say that, yes, we have to stent, or no, we don't have to. It's never a black or white true answer. Of course, we will have to make a black or white decision. As physicians, we cannot just half stent this lesion. So in the end, we will have to make a decision, black or white. But we have to keep all these nitty-gritties in our hands. Thank you.
Maybe, yes, Gianluca?
I just talking about this kind of prevent stenting or whatever. 5 years ago, we published a paper on left main, not stented, not treated. And we look computation fluid dynamic offline based on OCT imaging. And we have some cutoff of work shear stress, and actually we plan to have a cutoff for resident time to define which is the left main that probably we will close on follow-up or not. At that time, we found some cutoff value. So maybe that physiology is very okay and we are to rely on, but as Professor Pirro said, there are still some event when the FFR is negative but not so negative. So maybe that for prognostic vessel, I mean left main or LDA, LAD, we can have in the future some cutoff of not, I mean, of other physiological parameter derived from maybe CFD applied, for example, to CT scan and in the QFR. So maybe that the problem is not unilateral.
Yes, maybe here we will move to the concept of William Weiss about the radial stress and the measurement. Now they are working with Dr. Tu from Shanghai by measuring the radial stress. I know that Juan is involved in those projects, but maybe just to come more reliable, the global FFR here, because this is a patient with FFR 0.83 in LAD, 0.83 in right coronary artery. We don't know what is the circumflex, but it was clearly shown that if the global FFR on all coronary arteries is below 2.7, that means that it is less than 0.9 in O3 arteries. Those patients had a much poorer prognosis and much higher mortality than the rest of the patient. There is a paper from Dr. De Bruyn, I think it was in 2020 or 2021 in Circulation about the global FFR, and this is a typical patient exactly from this cohort. What do you think?
Yeah, I mean, I think it goes with atherosclerosis. We know also from CT data that the more atherosclerosis you have, the more events you do. But I would like to come back to your comment about this borderline value. Just one quick and short comment. Back in at the time they did DEFER, in DEFER, the cutoff was 0.75, and those patients, we have now follow-up of more than 10 years of those DEFER patients. They were deferred, they are more than 75, and they were doing fine. So I think I would not be worried about this patient, deferring a patient of 0.83. I understand your concern with the hydrostatic pressure effect, but again, that was included, this bias was in the trial, and those patients are doing well. So back to clinical outcomes, I think we can defer those patients safely.
So maximum medical therapy, optimum, let's say. Okay, so we don't have connection. Huh? Okay, so I think that we can go to lunch.